Welcome to The Explainer. Today we are breaking down one of the most sudden and severe medical emergencies out there, aortic dissection. Think of it as a catastrophic tear inside the body's main superhighway, and when it happens, the clock starts ticking fast.
Can you imagine a pain so intense, so out of the blue, that almost everybody who feels it, we're talking nearly 90%, describes it the exact same way? The worst ever. Yeah. This isn't some gradual ache. It's a sudden, ripping feeling that has you heading for the emergency room, like right now.
And you know that pain? It's basically a giant alarm bell for a brutal race against time. Because if this isn't treated, the mortality rate is a staggering 50% within just the first 24 hours. Let that sink in. For every 2 hours that go by, the chance of dying goes up by about 2%. So yeah, this is way more than just pain. It's one of the deadliest countdowns in all of medicine.
All right, so let's get into the mechanics of this. What is actually going on inside the body's biggest artery when this happens? What even is an aortic dissection?
Okay, so it all kicks off with a tiny tear. See, the inside wall of your aorta, called the intima, is supposed to be smooth, but if it tears, the high-pressure blood pumping from your heart just forces its way in. It gets between the layers of the artery wall and starts splitting them apart. It's kind of like prying open the layers of a piece of plywood, and that creates this brand new, really dangerous channel for blood to flow where it absolutely shouldn't be.
So let's stick with this superhighway analogy because it works really well. Your aorta, it's the main interstate highway for your blood, right? It goes from your heart to, well, everywhere. A dissection is like the asphalt on that highway suddenly splitting open, creating this dangerous rogue express lane right alongside the real one.
So this new channel, doctors call it the false lumen. And as more and more blood pours into it, it starts to swell. And it actually squeezes the real highway, the true lumen, shut. And that is the real danger here. All the off-ramps from that highway, the ones going to your brain, your kidneys, your legs, they get blocked off. And those organs start getting starved of blood. Okay, but here's a really crucial point. Not all dissections are created equal. Where that initial tear happens basically creates a massive fork in the road. And which path you go down can be the difference between life and death.
So doctors have a system for this. It's called the Stanford classification. Type A means the tear is in the ascending aorta. That's the big curved part right after the heart. This is the big one, an absolute drop-everything surgical emergency. Why? Because it can rupture into the sac around the heart, and that's usually game over. Type B, on the other hand, happens further down the line, in the part of the aorta that goes down through your chest.
And get this, look at the numbers. About 60% of all aortic dissections are the really, really bad kind, type A. So more often than not, when someone comes into the ER with this, they're on a fast track to the operating room for immediate open heart surgery.
So who gets this? Well, if you had to paint a picture of a typical patient, it's probably a man, somewhere between 50 and 70. But the number one culprit, by a long shot, is high blood pressure. Over 70% of patients have it. Just think of that constant pounding on the aorta's walls. And then you've got genetic stuff too, like Marfan syndrome, which weakens all your connective tissues and can put even young people at risk.
Okay, so picture the scene. We're in the emergency room. It's chaotic. The patient is in agony. How on earth do doctors figure out what's going on? And fast.
I mean, think about the challenge here. Your patient is in excruciating pain, their vitals are all over the place, and you have to get a clear picture of a tear inside the biggest, most important artery in the body. How do you even do that?
Well, they use some pretty incredible imaging tech. The MVP here is usually the CTA scan. That's a CT angiogram. It's basically a super fast, high-def CAT scan where they inject dye to make all your arteries light up. It's quick, it's crazy accurate, and it shows them the whole aorta. Sure, an MRI is also super accurate, but it just takes way too long. And in this situation, you just don't have that kind of time. And on that scan, this is the telltale sign they're looking for. You can literally see the flap of tissue that's creating those two channels. But the real oh no moment is when they see the original true lumen getting squeezed into this tiny little slit. That's the smoking gun. It's visual proof that organs are not getting the blood they need. Okay, so diagnosis is confirmed. Now the race is really on. It's all about fixing that tear. And the ways surgeons can do this today are pretty amazing.
So for a second, let's just talk about the type B dissections, the ones further down. For the longest time, the choices were
Well, not great. You could either try to control it with blood pressure meds and hope for the best, or you could go for this huge, risky open surgery where the mortality rate was like 30%. But things have totally changed. The real game changer here is something called TEVAR. Instead of cracking open the whole chest, surgeons can make just a tiny cut in the groin. Then they thread this special stent, it's like a fabric-covered tube, all the way up through your arteries. And when they get to the tear, they deploy it, basically patching the hole from the inside. It's incredible.
And the whole point of TEVAR is actually pretty brilliant. First, you seal the tear. That immediately takes the pressure off and lets the real artery, the true lumen, pop back open so blood can get where it needs to go. Then, because no new blood is getting into that false channel, it starts to clot up and shrink. And the big picture goal is what doctors call positive aortic remodeling. Basically, you're helping the aorta heal itself and get stronger for the future.
And look, the numbers don't lie. The data on this is really clear. If you just manage this with medication, the 5-year survival rate is about 71%. Not bad. But if you get an early TEVAR procedure, that number jumps up to almost 85%. That's a huge difference and a really strong case for this kind of intervention.
You know, getting through an aortic dissection is a massive, massive win. But surviving the emergency is really just the beginning. It's the start of a whole new chapter.
And this right here is probably the single most important thing for survivors to understand. This isn't like a broken arm that heals and you forget about it. The aorta is permanently changed. It's now a chronic condition that you have to manage for life.
So what does that management look like? Well, a few things are absolutely key. First, blood pressure has to be controlled, like aggressively. You want to put as little stress on that aorta as possible. That means medications, often beta blockers, to ease the force of the heartbeat. And, really importantly, it means getting regular scans to keep a close eye on the aorta and make sure nothing new is developing.
And there's a really good reason for all that scanning. Even when everything is managed perfectly, that weakened part of the aorta can start to balloon out over time. That's called an aneurysm. And it's not rare. Somewhere between a quarter and half of all survivors will eventually develop one. So you've got to watch for it. So all of this kind of leads to a really interesting question for the future, right? We know TEVAR works great for complicated cases, but as the tech gets even better and even safer, should we start using it on all type B dissections right from the get-go, instead of waiting for complications? It's a big question, and the answer could totally change how we treat this condition down the road.